This is how we always begin programs at the Commonwealth Club of California since 1903. And I want to say good evening and welcome to Commonwealth Club World Affairs here in San Francisco, to our in-person audience as well as an online audience. This is being live streamed. We are the nation's oldest and largest public affairs forum. Every year we present hundreds of forums on topics ranging across politics, culture, society, artificial intelligence, the economy, and more, including tonight, the future of healthcare. So I'm Robert Kilpatrick, and I'm the chair of the Health and Medicine member-led forum here at the Commonwealth Club and a member of the Board of Governors. First, some housekeeping. Please turn off your phone and other devices, and I had to remind myself to do that too. Later in the program, we will invite questions from the audience, both in person and online, so please write them down and pass them to somebody. I think, who's going to collect them? There we are, hands up, yes, there we are. Someone will collect them from you, and then I'll look at them. And I'll be given questions from the online audience. So after the program, there will be a reception sponsored by the University of San Francisco School of Nursing and Health Professions on the rooftop garden with a view across San Francisco Bay and the city, the waterfront. Today's program has been generously sponsored by the Gordon and Betty Moore Foundation, which was established to create positive outcomes for future generations. And in pursuit of that vision, they advance scientific discovery, environmental conservation, and the special character of the San Francisco Bay Area that we all love. They have been important contributors to the development of the nursing profession. Also, I think, helping to start the UC Davis School of Nursing. So today's program title sets the stage for an important discussion. We will hear about the future of healthcare that is unfolding and how nursing and public health are leading the way. Our speakers today are a dynamic trio of deans at the University of San Francisco School of Nursing and Health Professions, and this is not to be confused with UCSF, which is something completely different. I'm going to quickly introduce them and then ask the deans to come sit on the stage. Dr. Eileen Fry Bowers has a PhD and also a law degree, a JD degree, and she is the dean and professor of the school. Dr. Erin Grinstein, yay, is an associate dean. I call her Dean Erin, associate dean for health professions and associate professor in the school, and Dr. Megan O'Banion is associate professor and senior associate dean in the school. They are part of the impressive brain trust that powers the USF School of Nursing and Health Professions. Deans, please come forward. Thank you. Thank you. I'll switch those phones off.
Okay, well, thank you so much, Robert. We're so glad to be here tonight. As Robert said, I am the dean at the School of Nursing and Health Professions. He mentioned that I have a law degree, but I am first and foremost a nurse, a pediatric nurse practitioner, and clinical specialist. With me, I have Dr. Megan O'Banion, who is, in addition to being an extraordinary senior associate dean, is also a clinical psychologist. And then Dean Erin on the end. Erin has her PhD in public health and is an amazing researcher. So we are really thrilled to be here tonight to talk with you about the future of healthcare and how nursing and public health is leading the way. So I'd like to start this evening with a story, as they say, taken from the headlines. A community suffers from significant health inequity. Despite the expansion and specialization of medicine and healthcare, health disparities and health inequities persist. Maternal and infant mortality exceeds national averages. Economic challenges lead to unemployment among the working poor. Immigrant populations lack access to health care, and infectious disease creates significant morbidity. Questions of who has a right to health care and who pays for health care abound. Does this sound familiar, like any places you all know? Before I go on, go on and tell you a little bit about that community, I first want to sort of step back and ask, what do we mean when we talk about health, and what contributes to a state of health? Knowing this, then we can talk about the state of healthcare in the U.S. in 2024 and what we get for what we pay in terms of health, well-being, and the quality of life for those who live here. Historically and culturally, definitions of health abound, from concepts of balance, from health being considered an economic category, and health as a balance between person and the environment, the unity of the body and soul. All of these date back as far as Greece, as far as ancient Indian and Chinese medicine. And so while it's taken Western medicine a while to move away from health as simply being defined as the absence of illness or disease, we have generally now accepted a definition from the World Health Organization that defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. In fact, research tells us that about 80% of our health is attributable to factors other than healthcare, and countless studies indicate that access to healthcare and the quality of care mean less to one's overall health. More importantly, it's the education, the job, where somebody lives, and what kind of lifestyle they lead that impact health. So I'd like to talk just a little bit about healthcare right here in the United States. Healthcare spending, both per person and as a share of our gross domestic product, continues to be far higher in the United States than any other high-income country. Yet the U.S. is the only high-income country that does not guarantee health coverage to its population. The U.S. has the lowest expectancy of life expectancy at birth and the highest death rates for avoidable or treatable conditions, the highest maternal and infant mortality, and the highest rates of suicide among all Western economies. The U.S. also has the highest rate of people with multiple chronic conditions and an obesity rate twice the average of the 38 other highly industrialized or economic high to mid developing countries. And among these countries, in 2022, the U.S. ranked fourth worst for child poverty, with over 20% of children living in homes with incomes below the official poverty measure. And I raise this point specifically not simply because I'm a pediatric nurse practitioner, but children literally are our future, including our future workforce. Child poverty is the single most important determinant of a child's health, and it's remained stubbornly high for decades. Children of color are 2 to 3 more times likely to live in poverty than their white counterparts. And approximately 5 million children do not have health insurance. And if children do have health insurance, coverage varies substantially depending on where they live in the United States. Approximately 20% of adolescents have a diagnosable mental health disorder. And among children ages 15 to 19, suicide is the second leading cause of death. and the leading cause of death for 14 to 15-year-olds. Diseases of despair, or more specifically, those diseases that result from drug misuse and overdose, suicide, and alcohol misuse, or they impact people who have often a sense of despair due to their social and economic circumstances, have increased in the last decades. In fact, deaths from these three conditions have risen so much that they have been cited as the major contributor to the recent decline in overall life expectancy in the United States. While many lean into the idea that the U.S. is a leader in healthcare, especially with regards to technology, our healthcare expenditures remain higher than other developed nations, and we are ranked 37th among the world's health systems in overall performance. So let's go back to the community that I introduced at the start of this conversation. The community is New York City, but not today. The date is 1893. A young woman named Lillian Wald, 2 years beyond her graduation from New York Hospital Training School for Nurses and following a year working in the New York Juvenile Asylum, began teaching home nursing classes to immigrant populations of New York's Lower East Side. What she immediately understood was that health was and is determined by the environment and social conditions in which one lives, works, and plays. She responded by founding the Henry Street District Nursing Service, later renamed the Henry Street Settlement. Side note, she was also pivotal in the National Child Labor Reform and later founded the League of Free Nations, which is the precursor to the Foreign Policy Association. This is an example of what many of us know, that nursing and public health is indeed political. Today, the Henry Street Settlement still exists and has been a powerful force of social innovation for improving health and well-being. It's a place where healthcare for mental and physical needs are addressed, where maternal and infant mortality improve, where loneliness and social isolation, especially among seniors, is attended to, and where children have a safe place to learn and play and are supported by role models, and where housing and workforce development exists. What the Henry Street Settlement and many other individuals and organizations who work at the intersections of medicine, nursing, public health, and science understand is that environments where people are born, live, learn, work, play, worship, and age all affect a wide range of health, functioning, and quality of life outcomes and risks. Our understanding of health goes far beyond an individual's behaviors and is critical to approaching prevention more holistically. So we talk about the social determinants of health then as being things like education and access and quality to that education, healthcare and access and quality to that healthcare, the neighborhood and its built environment, the social and the community context, and economic stability. Yet, we have spent the 20th century and the initial decades of this 21st century building a sick care industrial complex rather than attending to developing health. In fact, just as a side note, and this is a perfect example of this, the licensing exam for registered nurses requires no coursework in community health. And this has led to schools of nursing focusing explicitly on educating nurses to care for individuals in the acute care setting or the hospital setting. About 80% of our curriculum historically has been focused on caring for individuals, providing sick care to these individuals instead of developing health. And as we continue to speak about health, I now turn to Dr. Megan O'Banion to share her thoughts on this topic.
Thank you so much, Eileen. So I'm going to start just kind of taking us back to the beginning of Eileen's conversation with all of us here and helping us really answer that question. So what truly is health and what is our healthcare system currently? So what is health? Eileen was talking earlier about how we have multiple different definitions. And one that really stands out tends to be one from the World Health Organization, from the WHO. And as Eileen pointed out also, that the WHO really clearly articulates this as a state of complete physical, mental, and social well-being, but not merely the absence of disease. We know that health is fundamentally multidimensional. And so it is truly comprised of several different aspects, from physical, intellectual, emotional, financial, occupational, environmental, social, and spiritual dimensions that we must take into consideration when we're thinking about the health and wellness of individuals. When I ask people, what is health, right? A lot of the answers that I get tend to be a blendo combo, or really unable to tether apart health and wellness. Most people talk about health, and they use the term health and wellness, well-being, completely interchangeably. Now, why is that? We know that they are different concepts, right? But they are truly deeply interconnected. So the primary relationship between health and wellness is that if health is our goal, right, then wellness is the active process of getting there. So health ultimately is on a continuum, right? We think of continuum, we think of our own lifespan. So my health from when I was a kid to when I was a teenager to when I was an adult, right? That is also on a continuum, but also when we think about a continuum of the entire lifespan of a population. Health is relational, and Eileen pointed this out incredibly beautifully, that when I talk about relationships, or we talk about relationships within health, we're talking about the relationship of the individual with the community, the individual with the environment, not only just with their body. And what is in our environments that can impact our health? Toxins, social stress, social influence. There's lots of different factors that can actually really impact our health, including early life adversity. We also know that health is not dichotomous. So what I mean by that is that good health and poor health don't occur as dichotomies. The absence of disease or disability is not sufficient or necessary to produce a good state of health or wellness in a person. So fundamentally, when we think about an individual's experience of health itself, it is both psychological and physical in nature. How I experience my health is both physical, how I feel in my body, but also how I emotionally feel, psychologically feel, and perceive my health to be. So as we were talking before, and this is gonna thread through the entire conversation today, is that there is an absolute interconnection between the body and the mind. That bridge may look familiar to some of you here, but there's an absolute connection between the body and the mind. And we can take this back even before Dr. Brock Chisholm, who was the first director of the WHO in 1954, and he coined the quote of basically saying there is no health without mental health. They coexist. They're interconnected. They're fundamentally tied together. We know from research that people with chronic disease are more likely to experience depression. And conversely, people with depression are more likely to develop chronic illness. They are inextricably connected together. My own personal experience, like some of you here, maybe, perhaps, experienced COVID, right? Just I'm just going to throw that out there. Possibly some of us did. And when I experienced COVID, the first symptoms were absolutely bodily. They were physical, right? But once the sore throat and the cough subsided, I was left gloomy and lethargic and with brain fog. So an infection in my body morphed to a short-lived experience of depression and cognitive symptoms. So there was no clear-cut distinction between my physical health and my mental health at that particular time. And in fact, we know that about 1 in 3 of our individuals that experience or are infected with COVID experience depression. Highly common. So there's this seamless interconnection of physical and mental health that is perfectly misaligned with our healthcare system's approach to dealing with sickness in the body and in the mind, as if they were completely independent from each other. So we have siloed and disconnected systems. Physical disease are treated by our medical providers, our nurses, our physicians who work in medical services. Mental health conditions, and those illnesses, those are treated by psychologists, counselors, and therapists. And we work in completely separately organized mental health services. It is a true separation, right? And the professionals, all these fabulous professionals, they are trained in divergent training systems with divergent career paths. So we have drawn the line between the two, the mind and the body. This line is now created for us a binary choice. This is a culturally imposed false distinction between the two, because we know that the mind and body are connected. So we've created a culturally imposed false distinction, a false dichotomy between the physical and emotional health, now across 2 separate systems. Okay, so we've created this fantastic fragmented approach to promoting and caring for health. And the impact of this is it disadvantages patients and it disadvantages communities. How does it do this? It does this by increasing costs. It does this by increasing stigma. It also impacts and holds back research. It creates silos in our research. It negatively impacts patient outcomes ultimately. So we need to clear the path to a healthy system of care, not a sick system, as Eileen was talking about before. And how do we do that? So we clear that path by focusing on caring for the whole person across all those dimensions we were talking about before of health and wellness. We focus on integrating the symptoms, not the symptoms, but the systems, and a truly integrated system of care that brings all of us care providers together under one roof. We reduce barriers to care. We increase services across the lifespan. We increase access in communities where we live, right? Where we work, where we play, where we pray, right? And we also expand Medicare reimbursement, right? We look at parity, we expand Medicare reimbursement to cover mental health services. And finally, we truly do need to take a population health or public health approach to our health. And I'll turn it over to Erin.
Thank you. So I'll talk a little bit about public health. And I want to start by framing what is public health. I think most people, especially after going through the last 4 years, have some sense of what public health is, but not really a good definition of what public health is. At its core, public health is population-level prevention. That's all it is. It's looking at prevention for larger groups of people rather than treatment at the individual level. So often it's easiest to juxtapose public health to medicine. If medicine is often individually focused, when somebody goes to see a provider, typically it is them alone seeking care for an illness or an injury or a sickness that they already have. Public health says, okay, let's take a step back, and instead of treating individuals after they already have a disease, let's prevent them from ever getting the disease in the first place. So I'm also going to tell a little bit of a story. This is just kind of a classic way to describe public health. Public health is focused on the upstream approach. That's often how we describe public health. It is an upstream approach to health and wellness. And what does that mean? There's a story that there's a river, and people are trying to cross the river, and they have to do so by going upstream and crossing at this narrower part of the river. But the river is a little bit wild, it has some rapids, and downstream, people are noticing that we keep having to rescue people once they're drowning. They get carried away on the river by these rapids, by the current, and then downstream, people are having to jump in or throw them life preservers to try to pull them from the river. Some people are saved, some people are not, and even those who are saved often have debilitating health consequences because of their near drowning. So then some smart public health person says, why are all these people drowning in the first place? And they walk upstream and they notice that there used to be a bridge across the river to get from one side to the other, and that bridge has collapsed. So rather than continuing to let people get carried downstream and throwing in life preserver after life preserver to save some of the people, why don't we build a bridge across the river to help people get from one side to the other safely, rather than saving them once they are already drowning? That's essentially the public health approach. Let's look upstream and try to figure out what are the deleterious consequences leading to people ending up in these negative health situations, and how can we put a bridge in place that will help prevent them from getting to that place in the end. So what does this look like in action? Public health tries to look upstream from clinical care. So essentially, at the community level, what can we do to improve community level factors that lead to the social determinants of health that Eileen was talking about? How do we impose better community conditions to improve the situations in which people live and work and play? How do we create systems of care that are more integrated, like Megan was mentioning? How do we create systems that address health for the whole person and not fragmented systems that force people to navigate multiple systems of care? How do we integrate those systems? And then beyond that, public health looks even farther upstream and says, what types of policies and laws and regulations do we need to put into place to minimize negative health consequences and amplify good health outcomes for people? Public health believes that prevention is the best medicine. So these are the top 10 public health achievements of the 20th century. And so you may not know much about public health, but you probably have a lot of familiarity with at least a few of these and understand how many of these have saved lives, possibly even among people who you know. Public health has looked to make the world a safer, healthier, and less sick place, and they've done so in a large variety of ways. In the 21st century, we have conquered additional public health achievements, such as reducing exposure to lead for children who we know have developing minds, and lead leads to really negative cognitive outcomes. We have improved cancer outcomes among people. There's a whole host of improvements in the 21st century, and we're tackling a lot more. This is a figure from the California Department of Public Health that shows the future state of public health specifically, and it focuses on foundational areas and foundational public health services, while also looking at the foundational principle, which focuses on equity, efficiency, and effectiveness of care. what does that look like in practice? I think if you asked anybody, what does the future of health or public health look like? Somebody would say technology. And it could be technology, and technology will play a role. It's in the technology that we have and how we integrate the vast amounts of data that we collect all day long. I mean, probably most of us in this room have a Fitbit or an Apple Watch or something collecting our health data constantly, or we have apps on our phone collecting data constantly. And so how do we integrate that data with clinical data to make decision-making more improved based on a more complete perspective of personal health. But it could be lots of other things as well. It could be the incentive structures that we put into place for how we pay people. Are we incentivizing prevention right now? I would argue not much. A little bit, and we're getting better, and clinical care is focusing more on prevention than it used to. But the change has been slow, and we are not necessarily incentivizing prevention as much as we are incentivizing treatment. And we need to think about that. There are a whole host of ways that we need to think about how to integrate public health with clinical care, because they're often operating as siloed systems. It's not just physical health and mental health that are siloed, but public health is often siloed as well. So, and I just want to close by saying that one thing that the pandemic has brought to light is how underfunded and under-resourced our public health systems are in the United States. And so I would say any successful future state really relies on increasing funding and increasing resources and strengthening our public health infrastructure in this country.
So thank you so much, Megan and Aaron. So I wanted to share with you a little bit about what we're doing at the University of San Francisco to lead in this space. It's not enough to continue to educate providers and professionals to go out and work in an existing system. We need to educate leaders who will change this system. We want to. And that's sort of our motto at USF, is to change the world from here. And of course, in the School of Nursing and Health Professions, we've changed it to say change the health of the world from here. But what we're doing is really looking deeply at our curriculum and how is it that we're able to leverage all of the knowledge, the technology, things like that Aaron and Megan were talking about, the lens through which we're looking at a whole person care, leveraging technology, and also thinking about how do we take that upstream approach. So really sharing a curriculum that attends to 4 spheres of care within the context of our social and planetary environments. So looking at wellness and disease prevention, looking at chronic disease management, looking at restorative and regenerative care, which is really where most of the focus has been. That's sort of the acute care model, the hospital model. And then also looking at hospice and palliative care. How is it that we can, support individuals from the very start of life all the way to the end of life, so that we're creating an environment that provides for well-being throughout this entire continuum. So we're undergoing specific curriculum overhauls in each of our programs, really trying to bring forth this sort of perspective so that we're able to go out and change. Our students are prepared to go out and lead these changes, and we're not just waiting for it to happen around us. We want to be the agents that create this movement. And so with that, I'm going to turn it over to Robert and
Thank you.
continue the conversation.
Well, hopefully, is this working? Because the one on my head apparently has failed. Thank you, the 3 deans. What a wonderful 3-pronged approach. And each were both different and yet totally related. And so I think I have a better picture. I am thinking about a quote from Charlie Mundy. How many of you know that name? He died at the age of 99, and he was the partner of Warren Buffett at Berkshire Hathaway. And let's face it, Berkshire Hathaway is all about money. And I'm very interested in the economics myself. And so here's the quote, and I want to open it up for a discussion. He says, "Show me the incentives, and I will show you the outcomes." That's for anything in the world, any business, doesn't matter what it is. Show me the incentives, and I will show you the outcomes. So when I hear about, a sick care, industrial complex, disease care, where do you think the incentives are for this red square in the upper left there? Because what I want to hear a little bit about is your vision, the three of you. How are we going to change this once and for all? And it must have to do with incentives, and it must have to do with money. And apparently, caring about people and praying and going to church and temples and all this stuff has not worked, because this has been something that societies have discussed for a very long time. And yet, I think the three of you have really good practical ideas. Can you throw something out about how to incentivize wellness and disease prevention?
Well, you've hit the nail on the head. I like to think about budget in terms of value. We only pay for those things that we truly value. Our budgets are only around those things that we truly value. So number one, we haven't come to a place where we truly value health and well-being in our communities. If we did, our federal budget would allocate more than 8% to children's well-being. So when we talk about, children being the future of our nation, we only allocate about 8% of the federal budget to their care and well-being. That says something about our values. So we've got something that we've got to resettle around value. I think the other thing that, from my standpoint, is that, it's kind of like you can't prove a negative. So it's very difficult to prove that you're keeping people well. It's very difficult to put money in and see the advantages of keeping people well. We certainly can see what it costs when there's illness, but it's really hard to put a number on it. And of course, Erin can talk more about this, putting numbers on that. But it's hard for the general public to see that. And when the general public doesn't see it, it's hard for them to vote for lawmakers and policymakers who will also see it. Our investments take a long time to pay off. If we invest, again, in a child's health, for every dollar that we put into a young child, it will pay off eightfold once they reach adulthood. But in between, we've got all kinds of different election cycles and different conversations about what values in those interim years. And so it makes it very difficult to incentivize moving in that direction.
Yeah, I completely agree. And I also completely agree that incentives work. And so we'll have to figure out how to incentivize prevention and focusing on wellness. And maybe that is in looking at value-based reimbursement strategies and getting insurers to incentivize prevention through reimbursing for prevention. The way that our healthcare system currently reimburses, we don't typically reimburse very much for prevention, and what we do reimburse is pretty limited. And so if we just change that structure, I think more prevention will happen within the healthcare setting.
I want to add to that coming from the space of the clinical psychologist, a lot of my practice was focused on individuals not actually in the state of distress, right? The majority of the practice, once we get through that acute level distress, is actually working with them on coping skills to reduce their stress in the future, right? But also thinking about how can they foresee challenges coming down the road for themselves so they can bolster their own and actually develop their own resiliency. So when we talk about incentive structures, Erin is also leading into and addressing reimbursement for other types of services that actually do improve overall health care, overall health and wellness of individuals, and so being able to expand medical services, in being able to expand reimbursement for mental health providers, for counselors, for therapists, not just within large institutions, but actually independent practitioners, that also is allowing people to spend their money, right, to actually use money and into places that they really do value, right? So if I really value my health and I want to go see a therapist, I want to be able to use my health insurance to be able to cover that. And I want my provider to be reimbursed in doing that. That also is placing some dollars where we actually value and need to be doing some intervention.
I just want to tag on to what Megan just said about health insurance as well, from an incentive standpoint. And this also gets to what Erin was saying too. We have to think about what is the incentive for our third-party payers. And when the majority of Americans get their health insurance still through their employment, we have to think about every time you change a job, your health insurer might change as well. What is the incentive then for that health insurer to support preventive and wellness kinds of services when they may not benefit from that 5 years, 10 years, 15 years down the road, because you'll have gone on to a different job and you'll be covered by a different third-party payer. So it's our system, it's not only aligning the systems with, aligning the incentives with what we value, but it's the system and how within that whole system can it work and can we benefit. We don't have things like frequent flyer rewards programs for, where you get to be with just one insurer as you move through your life. If you're being insured by multiple different payers, they're all going to have different incentives as to what they pay for and how long they're going to be willing to get a return on their investment in your healthcare. And I think that's a really important piece too.
Thank you. That makes sense. So on trains and planes and automobiles and picnics and dinner parties, I grab everybody I can find and talk about these things. And there is an elephant in the room always. And here's the elephant. Here's what the people outside the university in the silo say. They say, well, this is simple. In the United States, we need a national health insurance system. We don't need any more private insurance companies. Get rid of them, like Kaiser Permanente is the payer provider. And why don't we have a universal health care provision system? And it's I've lived and worked in the UK for 40 years. And there's a standing joke there. They say, well, you go into a hospital in the UK with blood pouring out of your nose, and the first thing they do is they run up and they say, where does it hurt? And you go into an American hospital and they say, who's your insurance provider? And so what people ask me, and I just want to throw this out for this audience, is why is healthcare in the United States run as a business versus public provision, like we rode on roads to get here today? I didn't pay a toll to drive on the road. It was paid through taxation. So since I've heard this issue talked about pretty much my entire adult life, do you think that we simply need an economic transformation of the payer system so that we no longer prioritize people with money who are deemed worthy and people who don't have money who are deemed unworthy? They're less worthy. Because even if you tie health insurance to employment, when people were losing health insurance during COVID, what a dumb system. Just when people need it to be cared for, suddenly they're thrown out on the street. So I know that's a political statement. You mentioned it was political, and I don't expect you to necessarily set the tone for the nation, but can you say anything about, maybe we're talking about economic incentives, because in the UK, I've met the Minister of Health, and the Minister of Health says, we're not perfect. We have a lot of problems to deal with, but since we, the government, are the payer, we have an incentive to reduce expenses and to increase outcomes. In the U.S., you have an incentive to have more sick people, more expensive operations, and no one's responsible for the health of the nation. So that's a lot. Does anyone want to be brave enough to respond to any of that?
Well, Erin and I have both taught this subject matter for many, many years. I will say that we have an excellent pilot in this, and that's in Medicare. We have a very good example of what you're talking about in terms of having the government have more control over the cost as well as the incentives that are part of the Medicare program. So, but Erin, I'm going to toss it over to you, see if you want to dive into this from the public health perspective.
Sure. Yeah, so I'll sort of answer it in a both and sort of way. If we had a different system, yes, we might be able to prioritize different outcomes, but we have the system that we have, and I think that I'm a bit pragmatic around whether or not we're going to, in any near term, really completely revolutionize the system in the United States. I do think that there are ways working within the current system that we can move the needle and we can incentivize prevention and wellness. It's not going to be easy, but there are ways to do it, and I think that we can do a better job than what we're doing right now. But again, it gets back to the incentives I think that we talked about when answering the last question.
Thank you. Now, I remember the very first time I visited all of you at USF, I was so impressed with the ethos of nursing and nurses, and this notion that, and you'll say something I'm sure in a moment about it, how you care for health, whereas medical schools pretty much teach people to diagnose, treat, and manage disease. And in fact, I had interviewed the head of a clinical medical school, which is famous, whose name I will not reveal, but it's famous. And he said to me, "Oh, we don't know anything about health. My job is to teach for medical students to diagnose, to treat, and manage disease, full stop," with an English accent. But anyway, so it's like but he said, but wellness is the ultimate goal, except you shouldn't expect us to be the leaders. So that opens the door to this wonderful question from someone in the audience, and you will know who you are. Nurses are still the most trusted profession. Why are they unable to leverage that trust to lead our policymakers and key financial entities to invest in nursing's priority on the value of public health? Let's have a round of applause for nurses. That's a good question, isn't it?
It's a great question, and it's a question that I think those of us who are nurses have been asking ourselves for as long as we've been nurses. There are about 4.3 million actively registered, nurses that are registered nurses. We have about 5 million if you include nurses who are licensed vocational or licensed practical nurses. So we are actually the largest health care workforce in the nation. And when you start talking globally, it's plus 20 million or so. So yeah, we're a collective force. We have a lot of long history, a lot of challenges in that history. We've had a lot of hurdles to overcome with regards to perceptions of what nurses do, who nurses are, what knowledge we have. I think that as a profession, we recognize very much that we need to leverage the trust that the public has in us. But again, when you have almost 5 million people, you've heard that phrase, herding cats. It can be a little challenging to speak with one voice. It also we have things like a media narrative out there that we are constantly fighting against. A lot of folks don't really understand that only about 50% of those nurses that I just mentioned work in hospitals, and the rest are out in the communities or in clinics or working for insurance companies or pharmaceutical companies or in schools. We're lots of places, but yet when people think about a nurse, they think about somebody within a hospital. And so all of that contributes to not being as historically effective as we would like to be in terms of moving the needle on this conversation. I think we're getting better at it as a profession. We are speaking more regularly with one voice, and I think that's what it's going to take. And we are using opportunities like this to come out and tell you what we do and how we can contribute on a larger scale. And we are also, ensuring that we bring along our other colleagues with us to the table, our mental health professionals, our public health professionals, because I think that's one thing that nurses understand is that it takes a team of individuals to move somebody along the health continuum.
I just wanted to add one thing, and that's that I think a lot of what we focus on when it comes to health policy is at the federal level, but a lot of where policy change is actually happening is at the state level and the local level. And since working in a school of nursing for the past 8 years, I've learned about an enormous amount of policy work that nurses do, including this nurse, at the state level in our own healthcare system within California. So while health policy in the news is always talked about on a more federal level, a lot of the change that's actually happening is within states and within local communities, and nurses have done an enormous amount of work in those policy environments.
Actually, I want to tag on to that, Erin. About 10, 15 years ago, a series of studies were published, and they looked at census districts, and they compared the health of census districts with the number of nurses who had an address in those census districts, and those areas that had more nurses living in those communities actually were healthier. By the measures that we use to look at like county health rankings and things like that. And what that says to me is that it's not just about where a nurse works. And I know this myself as being a nurse in the community. I can't tell you the number of times I've sat at one of my son's ball games and somebody comes up and says, "Can I ask you a question? Can I tell you about something? Will you, tell me, how should I handle this?" I think it goes back to that being trusted by the public. It gives us an opportunity to engage in conversation with an individual, with the community, and become part of that community and contribute to health in that way as well. So while we might not be making headlines, as Erin mentioned, I think we're changing health just in the way that we interact and live in our communities. And I would say that's the same for a multitude of healthcare providers.
Robert, you asked why. I just want to go back to the why question. And these fabulous colleagues talked quite a bit about how nurses are really leveraging that trust and making amazing policy changes. And I want to go back to the why a little bit in terms of some of the obstacles. We work within a society that really has layers and strata of power and privilege. And there are hierarchies in terms of that power and privilege. And I think that there is clear evidence, right, in research and in reality, and what we see, that different professions are given different space, time at the table in making change and having conversations based on where they're kind of placed in that hierarchy and based on how power systems determine where they should be, where they should fall. So that nurses may be the most trusted, but are they invited into the big spaces to have the big conversations? And though nursing is incredibly diverse in terms of a profession, the individuals that are in the profession of nursing, incredibly diverse. There is a narrative, right, out in the world that nurses and psychologists and a lot of other practitioners are women. And so that also really does describe where sometimes we are brought into conversation and able to be a part of decision making.
Yes, I must confess, many years ago, the very first time I met a man who said he was a nurse, I said, how is that possible? Because I'd seen only on TV programs, the nurses were always women and they had these white outfits with the hats on. Anyway, I've admitted I'm human. We all have false narratives in our heads, and I think I'm going to do everything in my power, beginning with today, to help you get your message out, because I think this notion of whole person health versus just cells and genes and atoms, a whole human being is what we are in this room, and that is not how most doctors think. That's not how they're trained, but nurses seem to be trained in this way. So that's very positive. We have a great question from the audience, and I'm going to set you up because the introduction to this is I've been to USF School of Nursing about 5 times now, and every time I've come, first off, I notice the students represent, the variety of peoples on the planet. It's a very ethnic, diverse campus, and I know you have a statistic about that. And also, they're also so happy. Unlike some other schools where I'm connected. So, you see a student at USF and say, where can I get a cup of coffee? Oh, I'll take you there. Oh, where is the library? Oh, I'll take you there. That never happens anywhere else. So here's the question. So you're doing something right, I think. It's amazing. What is the future of diversity in healthcare, both in populations needing care and in health care providers? And I know you're going to say something about the diversity of USF, aren't you?
Certainly.
I think so.
Yeah, we're the most diverse university in the country. We're extremely proud of that. And we, in our School of Nursing and Health Professions, we are what we would say majority-minority, meaning that we have a majority of students that are non-white. So we are really working hard to diversify our healthcare professions and nursing in particular. I think the really important thing to understand right now is that there is a significant imbalance in terms of the healthcare providers who are providing care and then the communities and individuals to whom they're providing that care. So we don't have a lot of providers, whether they be nurses, physicians, psychologists, public health, you name it. They don't necessarily look like, sound like, speak like the communities that they are serving. And so we're working very hard to make sure that we provide access to education for those populations so that they can come in, and whether they, go serve specifically in the community that they came from, or whether we are just diversifying the workforce as a whole, all of that is extremely important as we continue, as we know the United States continues to change in its demographic makeup. We want to make sure that our workforce changes along with that, so that, because culture, background, that nuanced understanding makes a huge difference in the kind of care that occurs and the way that communication occurs between a provider and a patient.
The figure that I showed you about California Department of Public Health's future state, one of their goals is to reduce disparities. If you look at Healthy People Goals, which are our nationwide benchmarks, it's all about reducing disparities in a variety of ways. And the only way that we're going to get there, I think, is to diversify the workforce and make sure that there are more people of every race, ethnicity, gender, ability, all sorts of diversity is represented in the public health and healthcare workforce. I think that that's critical. I think that it's something that USF is certainly playing a part in, but we have to do a better job.
So it is hard to believe, but as you can see on the wall there, we have 6 minutes left. So usually at this time, and tonight is no exception, I'm going to ask each of you to make, kind of what is the most important statement that you can make for this audience to take away as we go up to the third or the fourth floor. We go to the rooftop where we can carry forward our discussions more deeply and widely. And I do apologize to those of you who sent in excellent questions, but I simply lacked the time to go beyond the two I used, okay? So we can have them upstairs. So who would like to start? Each of you give a final takeaway, and then I'll give a wrap-up, and then we'll go have a drink. How about that?
I'll give it to you guys first.
I think that often when we have these discussions, it can sound full of despair. We've identified a lot of problems, and we all know from firsthand experience that there are a lot of problems in our systems of care. But I think that I remain hopeful that things are changing and there is positivity to be celebrated. And I think that we need to focus on small wins and not look for, I think, at my heart, when it comes to change, I'm an incrementalist. And so I'm happy to go from here to here, and then from here to here, and then from here to here. And I think often we are looking to go from here to here, and that's not necessarily going to fill us with a lot of hope. So I think that I would say, there are improvements that are happening, and we need to focus on those and focus on moving the needle a little bit, and we'll continue to do so.
As Eileen said, health is political, right? And if you care about something, then we will spend money on it. So I'm going to really bring in the catchphrase of the School of Nursing and Health Professions. And I'm going to ask all of you to change the health of the world from here by voting locally, right? Voting as often and frequently as you can, and really read what you're voting about, especially when it is talking about incentives, when it is talking about prevention, when it is talking about investing in healthcare, expanding Medicare. Lots of those kind of phrases that I want you to take with you as you leave this room today. And remember that, yes, health is political, but that is also where a lot of the change is going to occur.
And lastly, on building on both what Erin and Megan said, health is more than just you. Mm-hmm. Health is the environment. Health is the community you live in. Health are the people that you socialize with. Health is the books you read, the music you listen to. It really is about everything that you come in contact with that impacts you as an individual. And so we need to be thinking about that. And to Megan's point, it's when you're voting, it's about thinking about, what kind of environmental protections are being talked about, what kind of community, the built community. How's that going to impact the environment or the individuals who live in that neighborhood? It's all of these things together. We're all on this blue marble together, and our health individually, community-wise, collectively is tied to the health of our planet. And so I just would ask that you think of health broadly in that perspective as well.
Well, what I think I just heard for those in the audience here in person as well as online is that health is the requirement for every one of you to realize your hopes and dreams, for your children and families, for your friends, your communities, your brothers and sisters. And I think we mustn't forget that without health, nothing is possible. So support every initiative that extends health benefits to the population of the country. Let's get out the vote. Let's make it happen. So, round of applause to this amazing group. Thank you.